Hello, everyone. We will learn about the lung cancer today. The lung cancer, also called bronchopulmonary carcinoma, refers to the malignant tumor originating from bronchopulmonary mucosa or alveolar epithelium. In recent years, the incidence of lung cancer in the world has increased significantly. In industrially developed countries and China's metropolis, its incidence has ranked the first among tumors in men. At the end of the 20th century, the lung cancer became the leading cause of death in malignant tumor. The incidence age of lung cancer is above 40. Most lung cancers occurred in men, but the incidence in women has increased in recent years. The causes of lung cancer are still not completely known. Its risk factors mainly include smoking, air pollution, genetic susceptibility, genetic variation, etc. Among them, long-term smoking is the most important risk factor for lung cancer. As for distribution of lung cancer, it is more in right lung than left lung and more in upper lobe than lower lobe. Conventionally, the lung cancer that originates from the opening of the segmental bronchus and is located close to the hilum is referred to as the central lung cancer. The lung cancer that originates far away from the opening of the segmental bronchus and is located around the lung is referred to as the peripheral lung cancer. According to the differences of biological behavior, treatment and prognosis of lung cancer, we usually divide the lung cancer into two categories: small cell lung cancer and non-small cell lung cancer, squamous carcinoma and adenocarcinoma. At present, the most common pathological types of lung cancer are as follows. 1. Squamous cell carcinoma. It is closely related to smoking, mostly seen in men. Most squamous cell carcinoma originates from the larger bronchus, often in the central type. Their differentiation degrees are different. Most of them grow slowly, with a long course of disease. Central necrosis may occur, forming a posterior wall cavity. Usually, lymphatic metastasis occurs first, and hematogenous metastasis occurs later. 2. Adenocarcinoma. Its incidence has risen significantly over the past few years, surpassing that of squamous carcinoma, and has become the most common form of lung cancer. Its incidence age is usually less than that of squamous carcinoma and small cell lung cancer. Most of them are peripheral and usually grow slowly. Sometimes, hematogenous metastasis occurs in the early stage and lymphatic metastasis occurs later. 3. Small cell carcinoma. It is also related to smoking, more common in old men, in the central style. It originates from neuroendocrine, with high malignancy and fast growth. Lymphatic metastasis and hematogenous metastasis can occur very early. It is sensitive to radiation and chemotherapy, but rapidly produces drug resistance, with poor prognosis. The diffusion and metastasis of lung cancer are mainly direct diffusion, lymphatic metastasis and hematogenous metastasis. The most common sites of distant metastases of lung cancer are the lung, bone, brain, liver and adrenal gland. The clinical manifestations of lung cancer are closely related to the site, size, compression and invasion to adjacent organs and metastasis. Early lung cancers, especially peripheral lung cancer, often show no symptoms, most of which are found on by chest radiography or CT. Common clinical symptoms include cough, bloody sputum, chest pain, fever, and shortness of breath. Among them, the most common symptom is cough. When the cancer continues to grow up and blocks the bronchus, secondary pulmonary infection occurs, often accompanied by purulent sputum. Bloody sputum is common in the central lung cancer, usually with blood spots in the sputum. All respiratory symptoms that cannot be cured after 2 weeks of treatment, the possibility of lung cancer shall be considered. The compression or invasion of local advanced lung cancer to adjacent organs can produce corresponding symptoms and signs. For example, the compression or invasion to the phrenic nerve causes ipsilateral diaphragmatic paralysis. The compression to the recurrent laryngeal nerve causes hoarseness. The compression to the superior vena cava causes superior vena cava obstruction syndrome. The pleural dissemination causes pleural effusion and severe chest pain. The invasion to the mediastinum and compression to the esophagus can cause dysphagia. In addition, superior pulmonary sulcus tumor, also known as Pancoast tumor, is likely to cause Horner syndrome. As for a few cases of lung cancer, due to the production of endocrine substances, they can cause osteoarthrosis syndrome, Cushing's syndrome, and so on. Such syndrome can disappear after resection of the tumor. Therefore, early diagnosis is of important significance. Imaging examination methods include 1. Chest radiography. It is a commonly used clinical examination method, by which relatively typical lung lesions can be found. When the cancer metastases to hilum and mediastinal lymph nodes, hilum shadow or mediastinum shadow may appear. The combination of undilated upper lobe lung and hilum mass may lead to reverse S sign. 2. CT. With high resolution, it can show lesions with smaller diameters and lower density. The low-dose chest CT is currently the most effective means of lung cancer screening, by which early lung lesions can be found. 3. PET. Different uptake of radionuclide labeled deoxyglucose by normal nuclear tumor cell is used for imaging. The glucose metabolism of malignant tumors is higher than that of normal cells. The PET-CT developed in recent years combines the advantages of PET and CT, and improves the diagnostic efficiency and accuracy. 4. MRI. It is not a common examination method for the diagnosis of lung cancer, but it is of great significance for patients with iodine allergy who cannot be performed with enhanced CT and to determine the involvement of vascular nerve. Examination methods that help clarify the pathology include 1. Sputum cytology examination. It is the most commonly used qualitative diagnosis method, but the positive rate is low. Sputum should be sent for examination 3 times or more. 2. In addition, bronchoscopy, hydrothorax examination, mediastinoscopy, thoracoscopy and EBUS-TBNA are effective methods of pathological examination. As for differential diagnosis, it shall be mainly distinguished from pulmonary tuberculosis, pulmonary inflammation and benign tumor. The International TNM staging, the 8th version, is adopted as the present staging of lung cancer. This staging is suitable for non-small cell lung cancer and small cell lung cancer. There are significant differences in treatment programs and prognosis for different stages. Current treatment programs for lung cancer mainly include surgical treatment, radiotherapy, chemotherapy, targeted therapy, immunotherapy, etc. The principles for treatment of small cell lung cancer are largely different from that for non-small cell lung cancer. The distant metastasis of small cell lung cancer occurs early, except that the early patients are suitable for surgery. Other patients should be treated mainly by non-surgical treatment, while non-small cell lung cancer should be treated by TNM staging. Anatomic lobectomy and lymph node dissection are the first choice for lung cancer surgery. Early lung cancer surgery usually achieves the healing effect. Indications for surgical treatment are stage I-II and partially selected stage IIIA non-small cell lung cancer. The main surgical method is the video-assisted thoracoscopic surgery, which has the advantages of less trauma, faster recovery and better effect than the conventional thoracotomy. As for advanced lung cancer, the curative effect is poor, and the comprehensive treatment means suitable for patients are often selected according to the specific conditions of the patients. Thank you.